This operative video showcases the contralateral sublaminar approach performed using a unilateral biportal endoscopy for the management of a calcified lumbar disc herniation. The patient is a 48-year-old male who presented with chronic low back pain. He had bilateral L5 radiculopathy, more pronounced on the left side, and features of neurogenic claudication for over 6 months. Clinical examination revealed weakness of ankle dorsiflexion and extensor hallucis longus on both sides, along with approximately 30 to 40% sensory loss in bilateral L5 dermatomal distribution. The MRI imaging demonstrated an L4-5 disc herniation. Axial images showed compromise of both lateral recess as well as the central canal. The disc appeared hypointense on T2-weighted sequence, and in view of long-standing symptoms, a calcified disc was anticipated. The patient was position prone and docking was performed at L4-5 spinolaminar junction. Soft tissues within the interlaminar window were cleared to expose the inferior border of the upper lamina and the superior border of lower lamina. The lower edge of upper lamina was drilled to expose the upper margin of ligamentum flavum. Partial drilling at the root of spinous process was carried out to facilitate contralateral access, which also exposes the median fissure of the ligamentum flavum. The superficial layer of ligamentum flavum was removed, starting from the lower lamina, resulting in significant expansion of the working space. The medial half of the inferior facet was drilled, exposing the medial aspect of the superior facet, which marks the lateral attachment of deep layer of ligamentum flavum. The ligamentum flavum was subsequently disconnected circumferentially following a Z sequence, allowing controlled and safe decompression. At this stage, the thecal sac was seen bulging towards the contralateral side. An ipsilateral discectomy was first performed. The disc was found to be large and calcified. The annulus was incised using a number 15 blade, followed by piecemeal decompression. Here, the hard bulge of the disc compressing the traversing nerve root can be seen. The central canal component of the disc was removed through a transaxillary corridor. For the contralateral disc, instruments were advanced beneath the lamina, thus the sublaminar approach, with gentle retraction of the thecal sac. Using endoscope itself, the thecal sac was retracted. Annulotomy was performed using radiofrequency ablator, with complete contralateral disc decompression performed using a forward Babsy forceps. The use of forward Babsy forceps is very crucial in this technique. It not only allows removal of the herniated fragment, but it also allows a good decompression of the disc space under the annulus fibrosus, thus confirming a complete decompression. Once adequate intradiscal space was created, the contralateral foramina could be decompressed through an inside-out approach. This clearly demonstrates the feasibility and versatility of sublaminar technique in addressing even extreme lateral disc pathology using unilateral biportal endoscopy. Here, we are working on the contralateral intervertebral foramina under the superior facet, thus decompressing the contralateral exiting nerve root. The thecal sac is now completely decompressed. Also, the contralateral traversing nerve root and the ipsilateral traversing nerve root can be seen completely decompressed. Thus, the technique allows comprehensive decompression of the canal as well as bilateral lateral recess through a unilateral approach. The entire procedure was performed through a 8 mm working port along with a small stab incision for the weighing port. Postoperatively, the patient experienced complete relief of radicular pain. At 2 weeks, there was significant improvement in motor power, and by 6 weeks, he had returned to work and was completely symptom free.